Respect is earned, they say. In a world full of pain and violence, respect prevents lives from being shattered. A world with respect is where women run to their neighbors for sugar, not for help. It's where every husband and boyfriend is a partner, not an abuser. Where no street is ever seen as too dark. Where going to school or varsity is to get a degree, not lose my life. In South Africa, Ubuntu is our first language. Why have we lost our way?
Good morning. My name is Lenore Edwards, and I'd like to give everybody a very warm welcome to this webinar. Thank you so much for joining us. The title is a pretty big title on child pregnancy. Are we desensitized to abuse? Child pregnancy as a symptom, not the starting point. We'd really like to thank the GBVF Fund in partnership with the Mail and Guardian for arranging this very important seminar where we are going to discuss critical issues about the drivers of GBV and child pregnancy, particularly in South Africa. Thank you to the children's sector and to GBVF for the very valuable work they're doing to address these issues in South Africa. So we have a great panel of experts today who work in this field. What we're going to do is introduce them as we go through the agenda. We've got a lot to cover today and only an hour and a half. Mail and Guardian have said that we could go over by half an hour if need be, but we want to try and keep things within that time frame. So as we go through, we have questions prepared by GBVF Fund. And we'll be starting the program now. So the first speaker is Tandia Nzimande, who's the CEO of the fund, and she would like to begin with a welcome and opening remarks.
Thank you, Lenore. Good morning, everybody. And thank you so much for joining us for this very important conversation. On behalf of the Gender-Based Violence and Femicide Response Fund, it is my privilege to welcome you to the final installment of our intersectionality webinar series, hosted in partnership with the Mail and Guardian. Today's dialogue focuses on one of the most painful and urgent issues facing our country: the increasing prevalence of child pregnancy as a result of abuse, exploitation, and systemic failure. Today's webinar asks us to sit with a disturbing question: are we desensitized to abuse? The unfortunate truth is that the common usage of the term teen pregnancy has connotations such that when we refer to the pregnancy of 10 and 12-year and abuse that underlie these statistics, these pregnancies. We sanitize what in most cases is statutory rape. This conversation is not just about the number of children giving birth. It has the number of men who are impregnating children. It is time we put a sharper focus on identifying and tracking perpetrators. The name and age of perpetrators, the nature of relationship has to be recorded, as well as ensuring that every pregnancy involving a child under 16 is investigated as a potential case of rape. We cannot and must not allow these numbers to be reduced to health statistics alone. This is not merely a public health issue. It is a grave human rights violation, a justice issue. This webinar seeks to act as a springboard for catalyzing sector, not government, not private sector, not civil society, nor communities on their own can resolve this crisis. It is only through a multi-sectoral response that we can meaningfully protect children from abuse and show justice for survivors. Be strengthened. Statutory rape laws exist to protect children from sexualization, and yet too often they are inconsistently applied, under-enforced, or bypassed altogether. As a result, perpetrators walk free, while survivors carry lifelong trauma. Equally important is the need to establish strong community-rooted support systems for parents and caregivers. We must empower families with the tools, knowledge, and psychosocial support to recognize early signs of abuse, challenge harmful norms, and take protective action without fear or coercion into silence. As we mark Mandela Month, we are reminded of Madiba's enduring words. There can be no keener revelation of a society's soul than the way it treats its children. This moment calls on us to reflect. What is it that we are allowing? What are we complicit in enabling through our silence and inaction? Child pregnancy is not the starting point. It is the symptom of broken systems, silenced voices, and societal neglect. Together, we can begin to chart a different course. As the GBVF Response Fund, we remain steadfast in our commitment to support this mission by funding impactful interventions, driving advocacy, and mobilizing partners across sectors to prioritize prevention, protection, and justice for all our children. Today, we are privileged to be joined by our longstanding partners, and we will be hearing from UNICEF, Save the Children, the Nelson Mandela Children's Fund, the Department of Basic Education, the Teddy Bear Foundation, and community-based organizations. These voices represent the range of actors needed to drive a whole of society approach. And our task is not only to listen, but to decide and to act. To build a society where children are protected, not preyed upon. Let this be a time of recommitment and resolve to protect the children. Thank you for choosing to be a part of this critical conversation. And now I'll hand back to Lenore. Thank you.
Thank you so much, Tanvi. I did realize that I didn't introduce myself properly, so I do apologize for that. I am Lenore Edwards from an organization based in Durban, but working across Africa, Zoe Life Innovative Solutions. I'm the head of research and development. We work with children and adolescents and the ecosystems that they exist in, ensuring holistic health, including GBV and HIV as two of our main programs. So next we have a presentation by Ms. Makiba Yamano from UNICEF. There's going to be a presentation on data and research findings on child abuse and child pregnancy in South Africa, and these are aligned to the SDGs. So if you just give me a second, I will go through her bio. Just give me a sec. Sorry, I've just got it in the wrong order, so if you'll just give me a sec. Do I have it? Sorry. Makiba is an experienced humanitarian with over 20 years in child protection. As CEO of the child protection sector at UNICEF South Africa, She has led initiatives across 15 countries, including Yemen and Iraq. With a Master's in Development Study and a Childcare Work Certificate, Makiba is committed to advancing UNICEF's mission to protect children globally. I'll hand over to you.
Thank you so much, Reno. I would like to take this opportunity to thank GBVF Fund and the Mail and Guardian to organize this webinar, which is talking about important topic, which is child pregnancy. My name is Makiba Yamano. I'm Chief of Child Protection in UNICEF South Africa. Next slide, please. So during today's presentation, I would be touching three critical points. So one, as I have been requested to talk about sustainable development goals, how the teenage pregnancy or child pregnancy issue is aligned to the international commitment and what South Africa as a country committed to. Then after that, we will delve into South Africa's current data around child and teenage pregnancy and then related data. Then we will pose a critical question, which is the theme of today. Child and teenage pregnancy, is it just a lack of knowledge and we need to change behavior related to sexual reproductive health rights of the young people? Or it is actually related to child exploitation and an abuse that we really need to seek justice and then join our hands together to prevent this violence against children. Next slide, please. As some of you may already know, South Africa is committed to some of the sustainable development goals that are set internationally, and then I'm picking few that is relevant to today's topic. First, SDG target is 3.7, make sexual and reproductive health services available to all. And in particular for child and teenage pregnancy, the adolescent birth rate, aged 10 to 14 and 15 to 19 is relevant indicator here, which we will look into in a few minutes. Then the next indicator is eliminate all harmful practices such as child, early and forced marriage and FGM. This is related in particular if you are already married as a child below the age of 18, the likeliness of you getting pregnant is also quite high. The relevant indicator here is proportion of women aged 20 to 24 who are married or in a union before the age of 15 or before the age of 18. The last indicator is SDG 16.2, end abuse, exploitation, trafficking, and all forms of violence against and then torture of children. The relevant indicator here is proportion of women aged 18 to 29 who have experienced sexual abuse, sexual violence before the age 18. So we will try to look at some of these indicators as we go through the presentation today. Next slide, please. So this is the indicator related to adolescent birth, which is related to SDG 3.7. And as you can see, the average of sub-Saharan Africa in this continent, the adolescent fertility rate is 100 births per 1,000 women aged between 15 to 19. Compared to those countries, South Africa is actually doing better. As of the 2021 data, it shows 61. But if we are comparing ourselves with other upper middle income countries category, where the South Africa is categorized together, which is your China, Brazil, Indonesia, your BRICS countries, say, for example, we are actually having double the rate of the adolescent birth rate. And if we look at this data, for sub-Saharan Africa, the average rate of child marriage is around 31%, which is quite high, while South Africa's child marriage percentage is only 4%. So it is no wonder sub-Saharan Africa figure is much higher than South Africa. But why South Africa, with that low child marriage percentage of 4%, having very high adolescent fertility rate? We would like to unpack a little bit more in a next slide, please. Next slide, please. Thank you. So this is the South Africa specific data, and then we are trying to track maybe the last 10 years. And you can see there are downward trend up until the COVID-19 hit in 2020. The red line shows the 15 to 19 age category, and blue line shows the 10 to 14 age category. So if we first focus on the 15 to 19 age category, starting from 2012 up until 2022, we are generally showing a downward trend. However, when the COVID-19 hit, it actually went up. Fortunately, for the latest figures such as 2022 and 2023, we are again showing the downward trend, but we also need to remember our rate of births per 1,000 adolescents is still quite high. One of the most concerning things is the age category of 10 to 14. You can see the consistent increasing trend. And as Tandy, the CEO of GBVF Response Fund mentioned, if we know that there are for 10 to 14 years old child giving a birth, it is statutory rape. So we also need to be considerate of this increasing trend for the younger age group of the children. Next slide, please. We're going to unpack a little bit more on, so among who this teenage pregnancy or child pregnancy is prevalent. The data that is showing in front of us is from the Demographic Health Survey of 2016. Unfortunately, this is the latest data where we can get a bit of breakdown. The average of the national is 16%. Now, between the age group, that is, you can see the increasing trend as the age goes up. Now, what we also need to focus on is the difference between urban trend and then the rural trend. You can see urban is 14% versus rural is 90%. You can see that actually the rural community face much more risk of adolescent birth and child and teenage pregnancy. Next slide, please. This is the division by education background and then wealth quintile. You can see that primary incomplete cohort is having more than double percentage of the adolescent birth or the teenage pregnancy tendency compared to the other cohort group of primary complete, secondary complete, or secondary incomplete, but primary complete. So you can see that the education background is also a strong driver. And also the wealth quintile, you can see the poorest, the quintile has the highest. So there can be also an economic driver that is related to the teenage pregnancy in South Africa. Let us go to next slide. Thank you so much. I may not dwell on too much on the recent data, but I would like to highlight some of the key drivers, including that these are gender-based violence, poverty, and then limited sexual reproductive health rights, the stigma around contraception, and equal power dynamics in relationships. But what we also need to focus today is among recently pregnant adolescents that intimate partner violence was reported over 37%. And this means that they became pregnant due to the IPV. Next slide, please. Also, in the South African society, we need to consider that sexual offenses in general is disproportionately affecting children. Not only the recently pregnant adolescent girls reported that they have faced the intimate partner violence, that generally in South Africa, 40% of the total reported sexual crime against 40% of the total reported sexual crime are against children. The President Ramaphosa was saying that gender-based violence and femicide is the second pandemic in this country after COVID-19. But we rarely talk, 40% of that is against children. Considering the child population is 34% in South Africa, 40% means that children are disproportionately affected by the sexual offenses and sexual crimes in this country. Next slide, please. This is from the subcrime statistics, and then you can see the legend slightly small on the screen. But what you can see is the different crimes and proportion of that against children versus the total crime, which including adults and then the children. You can see murder, assault, grave bodily harm, and common assault or attempted murder, all hovering around less than 10% compared to the crime against adult. But when it comes to rape, sexual assault, and sexual offenses, you can see the percentage is substantially higher, over 40%. And this we need to consider as a strong background of why child and teenage pregnancy is rife in South African context. Next slide, please. As Tandy, the CEO of GBVF Fund, has already mentioned, we also need to perhaps reframe this discourse. Is it teenage pregnancy? When we say teenage pregnancy, people sometimes think of, oh, our young people, their behavior is not okay. Perhaps they may not have enough knowledge. Perhaps they need to be taught. But are we neglecting the aspect that this child pregnancy has happened because of exploitation and abuse? And should we correctly call it perhaps as a statutory rape? As we all know, the general age of sexual consent in South Africa is 16 years. And any sexual act with a person under the age of 16, even with a consent, can be considered as a criminal offense. Of course, there are exceptions. If consensual sexual activity between child aged 12 to 16 is now not criminalized. However, if the one party is over 16 and then other is under 16, still the statutory rape may apply, unless it is crossing age exceptions, which is typically in 2-year age gap. We are all reminded also that professionals, frontline workers such as social workers, teachers, health workers, we are all legally obliged to report any knowledge or reasonable suspicion of statutory rape or sexual abuse of a child to a police or social services. Now, we need to ask ourselves, if we are seeing the increasing trend of the child pregnancy age between 10 to 14, consistently over the last 10 years. And we are still seeing persistently high adolescent birth rate, age among 15 to 19. Are we missing something that we need to do, joining our hands together? And I think this is a question that we can also learn from today's panelist that follows my presentation. Thank you so much. I hand over to you, Renaud.
Thank you so much, Makiba, for presenting that data and giving us evidence that we really are facing a pandemic in South Africa, one that we need to address as a multi-sectoral approach. I'm going to allow 10 minutes to open the floor to everyone who has any questions and allow Makiba to answer on the data that she's presented. Are there any questions from anyone? Okay, if there are no questions, perhaps there were some that you think about later, then we can just, there is a Q&A section at the end and we can discuss those after. So we'll begin now with our first panel speaker, who is Ms. Lulu Tlatraneni from the Department of Basic Education. Thank you so much for joining us today. I would like to just give a brief introduction. So Delulu is a qualified professional with expertise in social development, gender equality and child protection. As the National Program Manager for the in-school gender equity programs At the Department of Basic Education, she leads initiatives to create inclusive environments for learners across South Africa. Welcome, and perhaps you could just come on and introduce yourself quickly.
Good morning. Good morning. Thank you, Lenore, and thank you to my esteemed guests as panelists, as well as everybody who is on the platform. As indicated, my name is Dululu and my surname is Hlachaneni, and I work for the National Department of Basic Education. I should and I must congratulate UNICEF by presenting such a wonderful data, and I don't think some of us that are working with government would really dispute that which has been indicated in that data. As the Department of Basic Education, we really want to express our appreciation to the GBV Fund as well as Mail and Guardian to allow us to make a contribution into this important discussion this morning. Mine is just really to talk around policies, particularly the policy on the prevention and management of learner pregnancies in schools, and then talk about legal and policy framework that talks to issues of educators as perpetrators, as well as also talking about the reintegration as well as the psychosocial support that the department is affording to our learners in our schools. First and foremost, I want to start with the policy on the prevention and management of learner pregnancy in schools, which is a policy that was established and developed and developed in 2021. And this represents a significant shift towards a rights-based, multisectoral approach, especially for learners who fall pregnant due to abuse or statutory rape. In terms of mandatory reporting, which UNICEF has started talking about, schools are legally obliged to report pregnancies involving learners under the age of 16, where the partner is older than 16, as this constitutes statutory rape under the Criminal Law Amendment Act. The protocol for the management and reporting of sexual abuse and harassment in schools also guides educators on how to report abuse to the SAPS and Child Protection Services. There is also integration support services where schools must activate school-based support teams and refer cases to district support teams for psychosocial support, counseling, and care. The policy further mandates collaboration with the Department of Social Development as well as Department of Health to ensure access to trauma-informed care and reproductive health services. There is also issues around confidentiality and dignity, where learners' privacy is protected, and schools must avoid stigmatization, and pregnant learners cannot be excluded from school and must be supported to continue their education. In terms of the implementation in high risks, schools and provinces, targeted provinces like KwaZulu-Natal, Eastern Cape, Limpopo, and Gauteng have been identified as high risks due to elevated rates of early unintended pregnancies and among learners aged 10 to 14. In terms of our policy rollout measures, as DPE, we have conducted and still do a lot of roundtable discussions, training workshops, and community mobilization campaigns to raise awareness and build capacity in these provinces, but also in all of the provinces, that even those that are not identified as high risks provinces. Schools are encouraged to develop context-specific implementation plans, including confidential reporting mechanisms and partnerships with local clinics, NGOs, as well as civil society. In terms of the monitoring and evaluation, as DPE, we are implementing a monitoring and evaluation framework to track policy uptake, school readiness, and learner outcomes, especially in rural and under-resourced areas. Now, coming to the second question around perpetrators of abuse or within the school system itself, what are the safeguards and enforcement mechanisms that exist to ensure that cases are not reported as statutory rape, but also trigger an appropriate child protection response and accountability for perpetrators? We all know that in the South African context, addressing abuse by educators requires a multi-layered response that goes beyond statutory rape classification to ensure child protection and accountability. And how do we try to do that? There is a number of legal policy frameworks, sexual offenses that define statutory rape and mandates reporting of sexual offenses against minors, the Children's Act that requires an adult who is aware of abuse to report it to a designated child protection authorities, Employment of Educators Act, which enables disciplinary action and dismissal of educators found guilty of misconduct, and the South African Schools Act, which empowers school governing bodies to enforce codes of conduct and initiate disciplinary processes. There is also an issue around mandatory vetting, where schools must obtain clearance from the National Register for Sex Offenders, which is the NRSO, and the National Child Protection Register, which is the NCPR, before hiring any staff. However, I should indicate that the implementation gaps exist, as many educators are hired before vetting is completed due to delays in certificate processing. We also have the protocol for reporting the sexual abuse, and this is the protocol for the management and reporting of sexual abuse and harassment in schools, which also outlines steps for schools to follow, including mandatory reporting to SAPS and child protection services. In terms of continuous monitoring, we encourage our SGBs to vet the staff almost every 2 years, and this I should indicate that it is not legally enforced. In terms of enforcement and accountability, educators found guilty of sexual offenses must be reported to SAPS and prosecuted under criminal law, and conviction may lead to inclusion in the NRSO and dismissal from teaching posts. Provincial departments refer cases to the Educator Labor Relations Councils for hearings, and the South African Council for Educators investigates breaches of professional ethics and can strike educators off the teaching register. And cases must be reported to the Department of Social Development for intervention and support. And schools must also continue engaging with their school-based support teams and district-based support teams to coordinate psychosocial support. In terms of reintegration, we know that the Department of Basic Education has taken deliberate steps to prioritize psychosocial support and trauma-informed care for learners who are survivors of abuse of pregnancy. And the overview is as follows. We use the Care and Support for Teaching and Learning framework, which is called CSTL. And that framework anchors the DBE's strategy for psychosocial support, integrating health, safety, and social services into the school environment. It emphasizes early identification, referral, and support for vulnerable learners. Once again, we continue using our school-based support teams, which are our core mechanism for identifying and responding to psychosocial needs of our learners. They are also responsible for coordinating care, counseling, and referrals to district-based support teams, as well as external partners. And we also utilize our learner support agents, which we have deployed them in high-risk schools in order to provide direct psychosocial support and facilitate referrals and monitor reintegration of pregnant learners. Through our ISHP, which is Integrated School Health Program, we offer an on-site health screenings, counseling, and referrals for learners affected by abuse, trauma, or pregnancy. And schools are also encouraged to shift from punitive discipline to understanding trauma-related behaviors. For an example, we are constantly engaging educators and train them to ask relevant and correct questions like, what has this child been through, rather than what's wrong with the child? And of course, with all this work, we are doing with the relevant partners, be it NGOs, be it civil society in general. There is also a lot of training and capacity building, where we are also exposing our educators for them to be able to recognize trauma and respond empathically. And this also includes our LSAs, as well as other support staff that we found in our schooling system. But what we do that also makes this training and capacity building much more relevant is the emphasis around the cultural sensitivity, the empowerment, and the collaboration with mental health professionals. At a school level, we do have a number of partners that we also work with, where we have developed resources like Khanyisa Ngemfundo Toolkit, where we guide educators in supporting pregnant learners through reintegration counseling and peer support. We also have developed the Guide for Learner Support Agents that outlines the protocol for screening, referral, and continuous monitoring. Schools, in terms of the referral pathways, schools must refer survivors to the Department of Social Development, the SAPS, and health services for protection and care. And we use Form 22 to report abuse cases triggering statutory interventions. In terms of monitoring and evaluation, we track the implementation through provincial reports and feedback from the SBSTs, which is our school-based support teams, as well as our LSAs, which are our learner support agents. And the high-risk provinces that I earlier mentioned, they do receive targeted support and oversight. Thank you very much for this opportunity. That is the input and the contribution that the Department of Basic Education has prepared this morning. Thank you, and back to you, Lenore.
Thank you so much, Delula. We really appreciate your inputs. As I said earlier, we have some questions that were prepared by the GBVF Fund. And I'll start with number one, if that's okay with you. So with the recently launched learner pregnancy policy, how is the department ensuring that schools are equipped to provide adequate support and care to learners who fall pregnant as a result of abuse or statutory rape? And how is the policy being implemented in high-risk schools and provinces?
Leno, thank you for those questions. I think in my response, I did indicate what are the activities or interventions that the department is actually proposing from the policy. Remember, I started talking about the mandatory reporting, which we know emanates from the legal frameworks of the Sexual Offences as well as the Children's Act. Educators are also obliged to actually ensure that they do report suspicion of such. I also indicated issues around our integrated support services, where I mentioned issues around the school-based support teams. And I should mention these are the teams of specialists that schools are supposed to gather for them to be able to assist in terms of dealing with issues around psychosocial support, around counseling, and around care. And I should indicate that we do largely work with the Department of Social Development as well as the Department of Health through our integrated school health program. In terms of also the one key thing that I want to mention around this is the issue around confidentiality, because we are aware that there is a lot of stigmatization that can result into trauma to these learners. And once again, educators or even the school community at large, through our campaigns, through our discussions, through our workshops, through our mobilization campaigns, we do emphasize the fact that the dignity of a learner should always be maintained. And in terms of the high risks provinces, we did do a rollout of the policy, right? And indicated that as much as we have high risk provinces like KwaZulu-Natal, like Eastern Cape, like Limpopo and Gauteng, we are not ignoring the rest of the other provinces in terms of that. And we do keep on ensuring that our educators, as well as the school community around those particular districts, we do raise awareness of these issues. We do capacitate them so that they are able to give support to the learners that have fallen pregnant. But once again, the mandatory reporting is what is key to this, because all these children that are giving birth in our health institution are children that are underage. I don't know whether there's something that I've forgotten, Leno, you would remind me.
No, I think that's perfect. Thank you so much for your input. We'll move on to the second member of our panel now, Mr. Anzo Jacobs. I'll just begin with a quick summary of his bio. He's a South African social justice practitioner with over a decade of experience in civil society and philanthropy. As the program officer at the Nelson Mandela Children's Fund, he leads initiatives focused on child participation, protection, and social justice. NGO works on issues of gender-based violence, inequality, and intergenerational trauma, with a focus on girls facing abuse and child pregnancy. He is committed to advancing inclusive governance and supporting marginalized children and communities. NGO, we'll hand over to you now.
Good morning, and thank you so much for the incredible opportunity to be part of this panel discussion. It's indeed an important discussion and links with much of the work that is being done by the Nelson Mandela Children's Fund in partnership with many of the partners who are indeed on this call. I don't have an extensive presentation, rather I prepared to respond to some of the questions, but I think at the core of what is being asked in today's discussion is, are we desensitized to this abuse? And I think the answer is emphatically yes. South Africans have become desensitized to violence, and we see this through the routine reporting of violence, and when major cases come up in the media and within our landscape, how quickly they dissipate. And we can look at just recent cases that have come up. We often have cases that are coming up related to child violence and maybe not particularly pregnancy. But what we see is that these cases are often linked to a particular child with a particular name, and that doesn't address necessarily that this is a wide and far-reaching issue that we are facing as South Africa. We've also seemed to, in the process of trying to address the issue of child pregnancy in schools, we've seemed to, through partnerships with government, also lessen the pressure for responsiveness, particularly when it comes to child pregnancy. And this is a double-edged sword, because on the one hand, we really rely on civil society to play this critical role of ensuring that we are data-driven in our approaches, that we foreground redress. But at the same time, this might be causing the adverse challenge of not overextending already overextended government resources, and ensuring that government does in fact hold the gap when there are gaps within policy and legislation. I think that it's important to note that some of the key concerns in this discussion, from the perspective of the Children's Fund, is that indeed we've got a learner pregnancy policy, which is non-binding in nature in terms of its implementation. And this is something that undermines some of the activism and advocacy that is being done in this area. Indeed, there's a lack of statutory readmission and a guarantee of redress in the mechanisms that we've put in place to protect learners that are pregnant. And then also, we noticed that there is a fragmentation between the approaches that have been taken. And that fragmentation we can really see between the departments of health and education, and particularly in instances of the child protection statutes that these departments follow. So there is a deep need for a collaborative and coordinated approach between health, education, and the Department of Social Development. I think in saying so, the work of the Children's Fund really does focus on a coalition-based approach, an advocacy that works with partners within the civil society landscape to ensure, in particular, that we frame child pregnancy as a protection lapse. And I think that this is one of the key calls within the South African National Child Rights Coalition and the work that it's trying to advance. I think it's also important that we intrinsically linked in the work that is being done with the South African National Child Rights Coalition, this particular advocacy around child pregnancy to the establishment of the Constitution, so that this is never out of sight in the advocacy work that's being taken on. Indeed, again, many of the partners that are on this call are part of that coalition. And so this is part of the work that is ongoing, and to ensure that it's entrenched in the approaches that are taken. I think it's also important to mention that as the Nelson Mandela Children's Fund, we use a data-driven advocacy approach. And so we are guided by the crime stats, and this was mentioned just by the previous speaker as well, Midlulu. And so this data-driven approach drives us to areas where the need is most pressing. We also note that when we use the disaggregated data of SAPS, we're able to go to those areas that are hardest hit by some of the crime stats that were earlier presented by Makiba as well. And when we go into those areas, what we're trying to do is really go to the furthest, the ones that are hardest to reach. Because what we find is that a lot of the programming that is being done is focused on densely populated areas. But those children, as were evidenced in Makiba's presentation, that are in rural areas, that are struggling for access to education, are often those that are hardest hit by the GBVF pandemic that we're facing, but also in particular then child pregnancy. And so advocacy in this instance, particularly coalition advocacy, and also the move in advocacy towards having the ORC move to a place that has power and weight and can actually do the work necessary and respond effectively is part of the work that is being done in the context of the coalition. I think then also when we build a community of practice that is informed by lived experiences, it is what makes our work more potent. So when we work in the context of coalitions at a national level, that's important, but to go into communities as we do as the Nelson Mandela Children's Fund is equally important, so that we are led by communities in interventions that are produced by those communities, in conversation with children who are affected by the issue that we're discussing of child pregnancy, but also violence more broadly. And these are the ways in which that data-driven advocacy really leads us to develop interventions that have a policy impact. I think then also it's important to mention that we do focus on child-led dialogue and testimony, so that the advocacy that is being, or the advocacy approach that is being implemented is indeed informed by lived realities of children. And so these are some of the approaches that we've taken. We've developed a significant amount of data. And I think the piece of data in particular that I'd like to elucidate in this conversation is really sorry, I'm just finding my note, is really the state of the South African Child Report, which we published in 2023. It really disaggregates the learner pregnancy rates. And what this helps with is actually putting data to the problem so that we know how to navigate it. We're also using mechanisms where children are speaking, not only in a local context, but in a regional context, such as with the Africa Children's Summit, which we just hosted a few months ago. And in these instances, what we're asking is for children to look at how it is that they can be part of making policy interventions, not only at a national level, but also at a regional level, so that the policy pressure comes from both sides, really, that it's on the ground pressure that is led by children themselves facing these issues, but that we also speak directly to policymakers at a national and a regional level. Maybe I can leave it at that for now. I do have quite a bit of a response, but I don't want to take up too much time on the panel.
Thank you so much, Anzio. Thank you for the incredible work you're doing with the Nelson Mandela Fund. Yeah, I really, really enjoyed the Children of the Voices and Adolescents and your approach to that, so that it is driven from both the top-down and the bottom-down level. So thank you very much for that. We can then move on to our third panel speaker, who is Megan Ann Brende, is that right? Who is the Programs Director of Save the Children South Africa. So quick bio is, Megan is a social development professional with over 30 years of experience in child protection, social welfare and public health. As the Director of Programs at Save the Children South Africa, she leads initiatives in child rights, education, nutrition, and sexual and reproductive health. Megan has held key roles, including Deputy Chief of Party for PACT South Africa, the USA PEPFAR-funded GCBS program. She holds an honors degree in social work and psychology and is pursuing a master's degree in social work. Nice to meet you, Megan.
Great. Thank you so much for inviting me on this panel. Yeah, just to help you a little, I'm Megan Brede. It is a tricky surname, but thank you so much. And thank you to my panel, to the other panelists. I think you've highlighted some very key areas already that we wanted to discuss. But I think very importantly, one of the questions posed to us as Save the Children South Africa was, what forms a strong national safeguarding framework? And I think in South Africa, we've made some really good strides. We have legislation. Our legislation is very clear. We heard that also from Department of Basic Education. Our challenge lies within a strong safeguarding framework is how consistently we actually apply that legislation. And I think that that is the first step in South Africa where we are already seeing the glaring gaps, that our legislation, our policies, we don't actually see them through. And part of the challenge there in that framework is it's actually not just about going out there and training people and making sure everybody knows the law and everybody knows the policy. It's about what do we put in place that supports our teachers, our nurses, our social workers, and our communities on the ground to actually see that legislation and those policies through to actual implementation, and in that way impact and then shift the needle for our young people that are succumbing to child abuse or falling pregnant at early ages. Very importantly, in our country, in a good framework, we need an independent oversight and coordination mechanism. In South Africa, that's the Office of the Rights of the Child. The challenge we sit with right now is that that office sits within the Department of Social Development, who is now responsible for both the implementation of a child protection system, but also the monitoring of it. And that is a conflict of interest. So if we're going to have a stronger oversight body to ensure that our legislation and policy is in place and is getting the outcome we want for our children, then we do need to see a shift of that ORC into the Office of the Presidency for a more neutral approach, and also to support an integrated safeguarding system. So one of the key things with an integrated safeguarding system that we're speaking about is we mention all the time how children fall through the cracks. So an integrated system should build a proper safety net, where if a child has fallen through the cracks, say in the education system, the health services are picking up on it, or social welfare, or the community. But we're not even seeing that. We're seeing children falling through the cracks in every single key point of support, to the point that we are losing them. And that is something that we need to very ardently address. I always like to give stories just to conceptualize what we mean. I was in a community the other day, and I noted we were at the clinic, and we noted at least 4 young girls coming for their prenatal checks, and they were definitely within the age range of about 12 to 14. And when I asked the clinic sister, have these young girls has this been escalated and reported to the Department of Social Development? The answer was no, because there was a fear that if you go deeper into the story with the young person, they will stop coming to the clinic. So the nursing sister was focusing on her need to provide the health services to the young person, but in that, the child protection concern continues and the risk to the child continues. So what do we do to ensure that that net closes in? So yes, if we address it with the child and she doesn't come to the clinic, then what is our community response? If we're able to do track and trace for HIV, why can we not do track and trace for a teenage pregnant young girl who has not come back to the clinic? So these are the challenges that we want to put out there, to say a good framework would see us not only putting in place our policies, but putting in place systems that support its implementation, not just training. We know training doesn't translate into action. Training is one step in the process of action. And that's what we're needing to look at. We need to ensure that we have trauma-informed and child-centered practices. So we start removing the victimization response, and that has come out from other speakers as well. How do we take away and desensitize? And very importantly, how do we shift this needle where we keep on addressing issues of child abuse of this nature, and particularly pregnancy, with girls, but not with young men? So if we're going to shift the needle, if we're going to have a comprehensive safeguarding framework, we need to have community-driven prevention. And this needs to be a strong framework that invests in norm change. And part of norm change is addressing issues such as gender inequality, poverty, and harmful social norms. I think Micah brought it up in the very beginning on how many young women who reported as pregnant also spoke about intimate partner violence. So we can't address this issue from one perspective, only from that of young women. How do we bring in the young men or even men to discuss redress? So as Save the Children South Africa, what is it that we like to do? Of course, the same approach with our partner Nelson Mandela Children's Fund and the National Coalition for Children's Rights. We work very stringently on advocating. But I think in this forum, I'd like to emphasize the need for a more community-driven response. So we like to move away from doing for communities. And I know now the talk is how we do with the community. We like to take that even further and say it's not even doing with, it's about how do we empower leadership that is driven from within the community to actually affect policy and to demand the services and the response that our children deserve. And we do this through active community participation, working with the community to identify how they would like to see the change and how they will lead that change. And of course, at the core is children and youth. Their voices is what can actually shift the needle more than anything, more than the voices of adults. We should be listening to the voices of children in how we could better address issues of abuse and pregnancy. I think that is central to what we do in our communities. I think the other key area when we speak about, I was asked to also just highlight, so from a civil society perspective, so we've got all our laws and our legislation, but that's our government response to trying to address the problem and seek redress for children. But as civil society stands as the civic monitor in the country, so ensuring that those legal obligations are enacted, that it's not swept under the carpet. You know, we're finding in communities that there's young girls pregnant, and then you find that the father is a repeat offender. You know, several young girls are pregnant from the same person. That is not a relationship. That is child abuse. And that is how we need to see it and frame it if we're going to make, take responsibility for this. So first of all, we need to be civic monitors. When it comes to civil society, we need to be those bridge builders as well as play the support provider role. So we need to ensure that there is support systems for young people who have fallen pregnant, and that includes our trauma response, especially if we know it is abuse has occurred in that situation. And we shouldn't be looking at teenage pregnancy for young girls to be treated as offenders or moral failures. We need to be looking at ourselves as the adults in society and as a country as the ones who have failed our children. So civil society also serves the role of championing our structural reforms. So very importantly, driving that shift of our overarching monitoring responsibility of the Office of the Rights of the Child, public education, norm changing, and very importantly, like we say, policy influence. So let's broaden the safety net and ensure that if a child falls through one crack, they don't fall through another and another and another and another. How do we tighten that and make sure that we all see our role as being responsible for reducing this? So thank you very much.
Thank you so much, Megan. I think in the interests of time, I'm just going to move right on to the next panel person, and that is Chanel Mohammed Thompson, who's the head of preventative services at Community Keepers NPC. Chanel is a registered counsellor and head of preventative services at Community Keepers NPC, where she oversees mental well-being initiatives in schools across the Western Cape, Gauteng, and Eastern Cape. Chanel joined in 2021 and has a B-Psych equivalent from the Cornerstone Institution with experience in schools, clinics, and correctional services. Over to you, Chanel.
Good morning, Leonore, and good morning, colleagues on the panel. So thank you, GBV Fund, for this wonderful opportunity to be part of this very important conversation. You know, when a young female makes her way to the clinic or to a social worker to set up an appointment, it can be quite scary and overwhelming. Knowing what to do and who to speak to, where to go, can be a challenge. So to respond to the question asked, what role does trauma-informed care and mental health support play in the work that Community Keepers does to protect child survivors of abuse, and how do we ensure that support is accessible in resource-constrained settings? Well, two key priorities are providing a safe space and removing barriers to access. So instead of expecting a young female to make her way to the social worker or the clinic, we bring the social workers and counselors to the school. Our services are on the school grounds and at no charge, and available to the learners, educators, and caregivers. So if the school is open, our office is open. And confidentiality is, of course, crucial. And we spend a lot of time building relationships in the school community. And in addition to our one-on-one support services, we run or facilitate life skill workshops throughout the year so that learners become familiar with us and a relationship is built on trust. We make ourselves more approachable. And we found that a vital element to building trust is providing consistent care, which Megan spoke about. Learners know that we are just a few steps away should they need support. For pregnant or abused learners, we might be the first adult that they disclose to, and our network of support services is our strength. We prioritize building and maintaining close relationships so that referral pathways are quick and efficient. Our team walks a full journey with the learner or the girl. Even if she's referred to another service, she remains in our care. And we ensure that she never feels alone or unsupported. So a second question was asked, how can community-based organizations like ours, especially in schools and homes, prevent abuse from escalating to the point of pregnancy? Are there any early warning signs or reporting pathways that work well at the local level? So when we on site or when we open up a new site, we invest a lot of time in destigmatizing help-seeking behaviors. We spend time in the classroom, the staff room, and attending parent evenings. We ensure that the school community understands that when they step into our rooms, it's a space where they can just be. It's a safe space, and it's okay to ask for help. And we found that there is a continuous flow of traffic into our rooms. Someone might pop in to share exciting news about a new hobby that they've taken on, like ice skating, or someone may come to disclose and get something off their chest. And I think that makes us fortunate. We are able to build those relationships of trust, and learners feel comfortable to open up. Educators, friends, or parents can refer someone to our rooms, or the learner can refer themselves. There's also a post box just outside our office where learners can drop a note and we'll follow up. And in our workshops, we discuss difficult topics, things that no one normally talks about. And the workshop is declared a safe space without judgment. And over time, the learners or the children start to speak openly or become aware of truths about topics that may have been normalized in the home or within the community. And then they feel confident to come and to book a session on their own. So when addressing a need, instead of just focusing on the negative aspects, we aim to empower learners to find solutions by focusing on their strengths and increasing protective factors. And
Thank you, Chanel.
okay. Now, just to respond to the final question, given the social stigma and silence surrounding abuse in some communities, what strategies have we found effective in building trust with children and families, especially when the abuser is a family member or someone respected in the community? Yes, sometimes the perpetrator is in the home, and sometimes it's the breadwinner. And the severity and complexity of cases are troubling. So we found that listening is vital. And often what is lacking for young children is someone to just listen. We listen and then often sit in silence and wait for more of the story to unfold. And sometimes it's hard for children to find the words to express themselves or to speak the words. And play therapy is a very helpful tool which we make use of. Young children, adolescents, and even adults sometimes find it easier to share their story through our sand tray figurines. And some stories actually take weeks to unfold. And we are privileged to be on the school grounds, as this really helps. And having a solid network means that when someone's safety is compromised, we can act very quickly. And safety plans are put in place when necessary in collaboration with other professionals to reduce the risk. And very important, each plan is uniquely tailored to the individual's needs. The principles are the same, but each strategy is based on what the young girl thinks and feels is important to her. Thank you, Leonore.
Thank you so much, Chanel. I'm now going to hand over to Shahiba Omar, the Clinical Director of Teddy Bear Foundation. This will be our last panelist, and then we'll go into a question and answer session at the end. Dr. Omar is a renowned social worker and mental health professional with over 35 years of experience in child protection and gender-based violence. As clinical director at the Teddy Bear Clinic, she developed one of Africa's leading diversion programs for young sex offenders. Shamiba is a prominent advocate for child abuse intervention, contributing to legal reforms and policy development in GBV and child protection. Over to you, Doctor.
Thank you, Lenore. Thank you, Emil and Guardian and GBVF. Indeed, a privilege to be amongst a host of panelists with experience and expertise. So I'm going to go quickly into it to just give quick background to the child pregnant learners. And I applaud Tandi and Sis Makiba for speaking to child pregnant learners, children birthing a child birthing a child. We cannot say, like it was mentioned, and that's been my long-standing argument, that a 10-year-old is not a teenager. So we were approached in 2020 by a school in Orange Farm where 20 learners were pregnant simultaneously at a specific school, and we went in blindfolded. We had to reach out. We had to look at what kind of support, what kind of work could we do? And that was our pilot, experience with child pregnant learners at the time. And subsequently, we just grew and mushroomed and started running programs across the province. So in the East Rand, we're running school, working with schools in Pretoria, Tshwane region, in Soweto, in Johannesburg. So we realized that the mental health of children is critical. And in response to that, last year in the East Rand, we had 5 children who had committed or completed suicide. Of the 5, 4 were young girls who had been impregnated, committing the suicide, and the one was a male learner who had impregnated his girlfriend. And because she completed suicide, he resorted to that drastic measure as well. And in response to that, we conducted a global action campaign, which we do annually with learners at schools, because we realize that teenage child pregnancy and suicide are global concerns, and that South Africa has the highest rate of child pregnancies, where we find that 1 in 4 girls are falling pregnant before the age of 19. And that is, the most recent stats from 2024. And the increased risk for suicide attempts, that is something that we felt we needed to explore, unpack the challenges that learners are grappling with. So we worked with 1,800 learners between the ages of 8 and above. And the questions that we asked these learners are, what are your thoughts about child pregnancy and suicide? Can child pregnancy lead to suicidal thoughts, and why? What role do you think families can play in the prevention of child pregnancy and suicide? And finally, do you think suicide is a solution to end the worry of child pregnancy? So just, I'm giving you a quick overview. We found that 90% of the learners agreed that child pregnancy can lead to suicide. And that indeed is very worrying, because already that means that they're seeing that as a way out, an escape, something so catastrophic, ending their lives. And of that, we found 11% of the learners felt that suicide is a solution to child pregnancy. And some of the themes that emerged from this study we found again, and I think the panelists have spoken to this, the stigma and judgment was one of the themes, where children felt that they were judged by their families, friends, peers, communities, and they considered suicide as an option. And because this kind of rejection and stigma led to shame and isolation, resulting in their withdrawal from their family context, from the community, etc. Then another theme that emerged was emotional and psychological impact. Here again, it was despair, fear, helplessness, which contributed to suicide. Some commits, just a verbatim quote, some learners commit suicide because they feel they've ruined their lives. And I think this again is absolutely disturbing. Another theme was the lack of support. Now we know support from families, schools, communities, and even from their peers, where they felt that they were labeled as a bad girl, one that you don't associate with, where other families refrained or restrained their children from engaging with these children. And so I think these are just some things that we have to appreciate and recognize. Then poverty and educational consequences, another theme. But I think what we found in our study was that the numerous times child pregnancy was mentioned in relation to poverty, particularly the children spoke to having to sell their bodies to provide for their families. So it's not just learner on learner, sexual impregnation or whatever. It's beyond that as well. And I want to just also make people aware that as we speak now, we are currently going to be starting on a study in the Eastern Corridor with 8 schools, where we are going to look at the root causes of child pregnancies. And this is actually in conjunction, in partnership with Section 27 and the Commission for Gender Equality. And that will be starting probably in the next 2 weeks, as DBE has approved it. We've got ethics approval because we realize that a lot of the learners have been impregnated by adults, by families, incest, and even by educators. And those cases are not reported. People are not on the NSRO, National Sex Register. And I think that's something that we need to establish, because if we want to be effective in our interventions, preventive programs, we have to look at what are the risk factors and hear from children themselves, nothing about us without us. And, getting that peer consultation, the bottom up, not the top down, hearing from the mouths of babes themselves, what is working, what is not working. Another theme was peer pressure and relationships, and often finding themselves in situations in a sexual relationship where they either have to give up the relationship if they refuse to engage in sexual intercourse, or the use of a condom. So that, that was something that came out very strongly as well. And a lot of them felt that as far as faith-based organizations, the religious and moral perspectives, where they were labeled as bad, as heathens, as people you don't go near to, I think that also contributed to the mental state and the high risk of suicide. A lot of the children did not go willfully. I think we need to be aware of that. It was not deliberate, not what we are hearing about girls wanting to get pregnant for the pursuit of social grants. A lot of it came out as unplanned and forced pregnancies, where there were instances of rape and incest, as I mentioned, and adult on learner. And we have to appreciate that what came out was that suicide was a response to despair, this feeling of hopelessness, helplessness, powerlessness, having failed their family, their parents, their loved ones. They felt this was the only way out for them. So if we look at strategies here, we can see, I think, and that's been already shared by the panelists, communication and support from parents. Another study that we had done with children in Orange Farm, and it was over 40 children who indicated that they felt information around sex and sexuality should have come from their biological parents, their primary caregivers, and a lot of them felt that that was not happening, and they resorted to other means of receiving information, also receiving guidance and prevention. And something that they gave input on was the lack of healthcare practitioners, educators, and other and even faith-based religious leaders not being able to engage with them, and their fear of engaging or seeking guidance because the fear of being judged, labeled, and being reported. So I think these are just some of the strategies that we feel that is important, and empowering families, empowering caretakers, caregivers on how to engage with children around sex and sexuality is important. And also having, I think it came from UNICEF and from others, the SRHR program, the Sexual Reproductive Health and Rights, where in our gender-based violence outreach programs, we speak a lot to, when does no mean no, and rights and responsibilities, and is it okay to say no, and their rights around that. So engaging people, making them aware that they can take a stand and should not be be misled or influenced because for being fear of being judged or labeled as somebody that is, you're just a tease, you can't do it, and will this relationship will not continue. So those are the kind of debates we have in the SRHR program. But again, engaging with parents, engaging with educators, engaging with healthcare professionals as well on how to communicate with children. The lack of sensitivity, empathy, being non-judgmental is key in ensuring that children come forward, seeking support, guidance, if they have concerns, that they will reach out and get the necessary information, because we know that information is knowledge, knowledge is power, and power liberates people, and certainly will liberate children when they have that kind of information to make informed, positive choices. Thank you.
Thank you so much, Dr. Omar. We're doing pretty well for time. It probably leaves us about 10 minutes or 15 minutes to open up for questions and answers. If anybody from the audience has any questions, just general or specifically directed to any of the panel members, feel free to ask those questions now. I see questions in the comments section. Some may already have been answered. So I would ask that if you do have a question, could you take the opportunity to do so now? If we don't, if we're not able to cover them today, then we're hoping that in the future there are more conversations, and we're really hoping that this webinar stimulates dialogue outside of this webinar between sectors and between organizations working within this field. So if I can open up the floor now to people who have questions for the panel. Okay, if there are no questions from the panel, then I'd like to end off today saying thank you to everyone involved. Thank you to every member of the panel for bringing to this webinar your expertise, the work that you're doing on the ground, the work that you're doing in advocacy. And in closing, we'd like to say thank you to the fund and to Mail and Guardian. We would like to indicate as well that the fund is planning an initiative to focus on GBVF in school, and that a report will be shared with the stakeholders to summarize the takeaways. We hope that partners in the sector will continue strengthening collaboration and developing solutions and sustained action to protect children from abuse and sexual exploitation. That's all from my side. If there are any closing comments from anyone else, please do feel free. But once again, thank you so much for this valuable time and for everyone who joined us today.
Hi, Leonor. I just see that Faith asked a question. She was asking what is our reach and how many schools and where. So currently we have 89 offices open in 89 schools, and they are in the Eastern Cape, the Western Cape, and in Gauteng. And thank you for your question, Faith.
Leonor, if I can say something, please. I would just like to bring it to the attention of everybody that we've developed content, we've developed a lot of material, we've got a whole training manual where we equip and empower facilitators to run support groups. We are currently working with DSD Gauteng, and where the different corridors are going to be trained in the first week of August. We will also be training the team at the National Command Center for GBV, so that they are equipped on how to reach out to children or child pregnant learners as first responders as well. I just wanted to say that we would share our material. We would be happy to train people if they are interested. Thank you.
Perhaps if I could, I see that there's a question in the chat around content creators and creating content. And I think that it might be important to mention that as the Nelson Mandela Children's Fund, we'll be launching a brown bag series that will focus on tech-facilitated gender-based violence and femicide, and also looking at the digital safety landscape quite comprehensively. That will kick off with the report launch of the Africa Children's Summit, which I spoke to as part of the presentation made, and that will go until the end of the year, culminating in a summit with 100 girls and boys that will focus on what tech-facilitated gender-based violence is doing in their context at the end of the year during the 16 days of activism against women and children.